Okay, and if there's any issues that you guys have while we're doing this, just let me know and I'll try to fix that. Okay, so we're gonna start. All right. See if it works. All right, question 1. So it's identifying the structure labeled as 2. Yeah, so this one was the brachial plexus. I don't know if this is accurate. Someone had texted this to me in one of our groups that some of the stuff that he went over in today's thing this morning, 9 and 10 o'clock, that was something like 60% of the pins. I don't know if he said that. I had gotten off, I think. I didn't catch him saying that. But so I went, and a lot of these pictures, I went and I took them pretty much directly from his lectures. Let me see what you guys say. Yeah, he did say that. Now, whether or not he actually sticks with that, that remains to be seen. But anyway, so let's go ahead and I'll flip to this. So I went ahead and blew up the picture here. So on this, you got 4 structures right here. 3 of them were scalenes, and then 1 of them has the structures running through the interscalene. Let's see what we got. Okay, so this one labeled as number 1, if I remember right, this one was the anterior scalene. And so if you remember, there's these structures running through between the anterior scalene and then the one adjacent to it, which would be the middle scalene. And so that space, which is more of a triangle, but that space between those 2 muscles, that's the interscalene space. And so that's where the brachial plexus runs through as it approaches the clavicle, that region of the axilla. So at this point, so here's the brachial plexus number 2. Below that, you've got the middle scalene, and then, at least in the picture below that, would be the posterior scalene. Let's see. Yeah, definitely true. In fact, I have a question on that coming up pretty soon. So yeah, when you're looking at this though, the thing that I want to emphasize about the brachial plexus is that when you're at this level, so at this point, they're just running through the interscalene space. They would not have formed the trunks yet. So when you're going through the brachial plexus, you've got the roots, which are the ventral rami, and then you have the trunks, and then they give different contributions, divisions, and then you have the cords. So at this point, they have, I don't know if I said that right, they haven't formed the cords yet because they just emerged from that interscalene space. So they really won't have formed the cords yet until they actually get to really right when they get to the axilla. So that's pretty much once they cross through under the clavicle above the first rib. So at this point, they would probably only be trunks, not the cords yet. Yeah, definitely. And so remember, if you have any 4 structures like that, I have a feeling that run parallel, that he's probably doing something with the scalenes and then the brachial plexus. So Randy Travis drinks cold beer. That's a good one. Yeah. So number 2 is the brachial plexus. All right, let's do that. And so now let's go to the next one, which is a follow-up question to that. All right. What other structure travels in the interscalene space? Yes. So I think it was Jeremiah that actually said that a few minutes ago. So yeah, when you're looking at, there's 2 structures that are traveling in that interscalene space. No problem. So you've got the brachial plexus, the trunks that are coming through there, and then you also have the subclavian artery. So remember that, and this is just an aside, but remember that the subclavian artery doesn't actually become the axillary artery until it gets basically under the clavicle across the border of the first rib, the lateral border lateral superior border. When it crosses the first rib, basically, then it becomes the axillary artery. And we probably still need to know the branches of the axillary artery. So if you remember going back to one of the PowerPoints that he had, there was a first division of it, and then there was a second division that was underneath or deep to the pectoralis minor, and then there was a third division. And one of the helpful things, if you're remembering those three, all the branches in those three regions of the axillary artery, remember that region 1 has 1 branch, region 2 has 2 branches, and region 3 has 3 branches. So that can be a way to mentally organize that. But subclavian artery is what actually goes through the interscalene space. And then, so it can't be axillary artery because it would not have crossed the clavicle and rib at that point. And then the other thing to remember is that subclavian vein, even though it's going the opposite direction, it actually does not traverse through the interscalene space. Someone correct me on this, but I believe it actually goes anterior to the anterior scalene. I think it goes anterior to the anterior scalene. I have to look at a picture, but I know definitely the vein does not go through the interscalene space. I think it goes anterior to it. Yeah, cool. All right, thanks, Jeremiah. All right, so any questions on this? Okay, let's go to the next one. So different topic. Identify the structure labeled as number 1 near the brachioradialis. Yes, yeah, so this one, let me actually go to the picture right here, next one. So, yeah, move this. So yeah, here's the brachioradialis, and I know he wouldn't actually give you that on the final, but just because we're not looking at a video zooming in or whatever for perspective, I just thought I'd label it so you at least know relatively where we are. So this muscle was the brachioradialis. And so what that should tell you is, first of all, if you can identify that muscle, the radius, remember, is on the lateral side of, at least when you're in anatomical position, it's on the lateral side of your forearm. So that means over here would be closer to the radial aspect. And then with this, to be honest, we would see the hand, but we're really kind of, at least right here, going to be in the more or less the extensor compartment. So this one was the one it was talking about. This would have been extensor carpi radialis longus. One note here, this one, the muscle kind of right underneath that. In the video, he kind of pulled this up and kind of exposed this one a little bit more. This one would have been.
Here we go, he's so ballistic. It's a cold video, we so with this shit. I'ma flow like a Tokyo, we kicked in. Make a dope so I know we lived in. And I say what I text like, can you still come over like.
Anyway, but this muscle, the one that's underneath.
You know, that was kind of where I've been at. It's beautiful. Feel that. Well, we'd love to hear another song, man, if you've got it in you, and I know you do. I do. The question is does my interface have it?
Going on.
Have it in it.
What's an interface?
What is an interface?
Let me, okay. Okay. All right. In any case, see if I can't edit that out whenever I post this anyway. But anyway, so here we got brachioradialis. Sorry about that. And then, was that really hacked? Or was that? All right. So, well, let's get on with it. Brachioradialis. And the number 1 right here, this would have been extensor carpi radialis longus. So that was the answer to that question, extensor carpi radialis longus. Remember that this one, when you're looking at, we can't really see it too much here, but remember when you're looking at the insertion or the distal attachment, remember that this muscle inserts on the 2nd digit, so index finger. And then when you're looking at the brevis, extensor carpi radialis brevis, that one's on the middle finger, so digit 3. So make sure to remember that. But then another way that you can tell which muscle this is you've got these two muscles right here, which were also answer choices. The muscle bellies of these kind of go around extensor carpi radialis longus. And so those were the other choices. So the one that's closer, or more proximal, I should say, number 3, that was the abductor. So that was abductor pollicis longus. And then the other one, which, let's see right here, is the one that's more distal. So it sits next to abductor pollicis longus, number 2. That one was your extensor pollicis brevis. And this one, again, that one wasn't even labeled, but that one's going to be underneath extensor carpi radialis longus right here. Would actually be this, the brevis one is right underneath that. I guess with this one, again, I took the picture straight off of his lecture today, or the other day, but remember that with longus and brevis right here in the extensor compartment, remember that longus inserts on digit 2, brevis inserts on digit 3, and then if you could look over on top of these two, you would see that their fibers, the tendons, project toward the thumb. And since abductor pollicis longus, the abductor has to be on the outside of the thumb, you're going to see that the tendon of this one's going to project more laterally, whereas the flexor has to be more in a little bit, whereas the abductor's out. So technically, the flexor is going to insert a little bit more medially. And so if I remember right, these two tendons at some point when they get over here, they kind of cross a little bit in order for this one to actually be the abductor and this one to be the flexor. Okay. So any questions with that one? Let's get on to the next question. Move past that. So this one I think is a follow-up. What nerve innervates structure number 1? This should only be one answer, I apologize. Yeah, so this one, I don't know. It said dual answer. I don't know what that means. Now this is right. So this one is innervated by the radial nerve. So again, it was talking about the same one from the previous question. So here we've got extensor carpi radialis longus. And if you go back to the PowerPoints, this one is innervated by the radial nerve. So if you remember with the radial nerve, it kind of crosses adjacent to the, let me admit, there we go. So remember the radial nerve kind of crosses the elbow joint a little bit lateral to the cubital fossa, right? So it's going to cross a little bit lateral to that on the thumb side, but it doesn't get very far. You'll go a little bit into the forearm, just a little bit, but remember, as soon as it crosses the elbow joint, it bifurcates, and you got a superficial radial nerve, and then you got a deep radial nerve. And then the superficial one would just continue down toward the hand, and that one is only sensory, so it only provides sensory innervation to really the thumb aspect, that side of the hand, the lateral part of the hand, more or less. But then that deep branch, it will go just a little bit. You'll have a little bit of a deep branch up close to the elbow, but then that deep branch enters that hole in the supinator, which is something that he's been hitting at a lot. So I feel like that's going to be something either big on the lab or the regular final. Arcata Frosch. Yeah. I don't know if you guys can see this, but Jeremiah said thumb side and the posterior hand only. Yeah, definitely. And so when it goes into that Arcata Frosch, that's where it enters the supinator tunnel, and it changes names to posterior interosseous nerve, which we'll come back and see that later. But the reason I mention that is because if you look in the PowerPoints, extensor carpi radialis longus is innervated by the radial nerve, but then the brevis is innervated by the deep branch of the radial nerve. So after the radial nerve divides into the two branches, then the deep branch gives off some branches, and one of them goes to the brevis part of this muscle, extensor carpi radialis brevis. So, and these ones right here, so 2 and 3, these are considered, I think they're considered, they're deeper muscles, I believe, in the extensor compartment. And so being deep in the extensor, they're going to be innervated by posterior interosseous nerve, which if you think about it makes sense because they're further down the forearm. So by the time the deep branch has gotten down, deep branch of the radial nerve has gotten down to this point, it's already turned into the posterior interosseous nerve. So abductor pollicis longus, and this one would be extensor pollicis brevis. Those are going to be innervated by the posterior interosseous nerve. Okay, next question. Yeah, so longus was just radial. And again, that's in the extensor PowerPoint on his in Canvas. Identify the structure number 3 around the anatomical snuff box. It's right there. Number 3 is this one. Yes. All right. So I got a picture of this too. All right. So we were looking at, so here's our anatomical snuff box. Let's see. Okay, anatomical snuff box. And there's 3 structures around here that he talked about. Only 2 of them actually make up the anatomical snuff box. So this one, number 3, that's what the question was. So that one is extensor pollicis longus. And when you look at this muscle, well, this is the tendon of the muscle. We can't really see it here, but if you followed it out to the end of the thumb, remember that you can tell the difference between these because extensor pollicis longus, this one goes all the way to the distal phalanx of the thumb. So the thumb has 2 phalanges, right? It has a distal one and a proximal one. This one way you could, I think about it in terms of its name, longus, extensor pollicis longus, is it goes all the way out to the distal phalanx. Okay? What do you guys think number 2 is? The one that makes up the other boundary of the anatomical snuff box. What's number 2? Yeah. So that's the one on the other side. So the snuff box has the longus on one side, and then this one number 2 is extensor pollicis brevis, which was another choice. And then the one just flanking that, number 1, on the other side of extensor pollicis brevis would be the abductor pollicis brevis. Because if you remember from the, I think it was like the previous slide, abductor pollicis brevis is kind of right next to extensor pollicis brevis. But these 2, the brevis and the extensor pollicis longus, they kind of make up the boundaries of that anatomical snuff box. Yeah, APL, yeah. Yeah, this one, number 1, is adductor pollicis longus. And so we're gonna have a follow-up question of that, I believe. Let's see, maybe we won't, we'll see. I don't know why it says multi-select, so don't worry about that. What nerve innervates number 3? Yes. So on these muscles right here, so this really goes, let's see, we got, yeah, extensor pollicis longus. Number 2 is extensor pollicis brevis, and then number 1 is abductor pollicis longus. I think I have it somewhere in here. Let me just check very quickly. If I don't, I'll just go back. Let me see, what is this? Deep, superficial, posterior. I may not have it here. But basically, when you're looking at the extensor compartment, most of the muscles that you see down toward the distal end, where are we? Having a hard time today. Anyway, most of the muscles that you see down toward the distal end of the forearm in the posterior compartment. So that's on this side of the forearm, right? Those muscles tend to be innervated by the posterior interosseous nerve. In fact, if you go back and look at the PowerPoints, you'll see pretty much all of these are going to be posterior interosseous nerve, because when you go back, when you look at the deep branch of the radial nerve, when it enters that supinator tunnel through the arcade of Frosch, which would be somewhere up here on the right side of the picture, deep branch of the radial nerve goes through that supinator tunnel, and when it does that, it becomes the posterior interosseous nerve. So a lot of those structures, the muscles that is, in the extensor compartment down here, particularly the deep structures, they're all going to be innervated by the posterior interosseous nerve down here. So if it's one of the deeper muscles and it's extensor, it's a good bet that's going to be the innervation on it. Okay? It can't be the radial nerve because remember the radial nerve terminates pretty much right by the cubital fossa, so up by the elbow. So it can't be radial nerve. And then the deep radial nerve only exists for a really short time, I guess you could say, really short distance, because it's going to bifurcate from the radial nerve, and then it enters the supinator tunnel, and then it becomes posterior interosseous. So deep radial only innervates two structures, and I believe it's really just, I believe it's the supinator and extensor carpi radialis brevis are deep radial. Other than that, it really doesn't innervate much else that we talked about. And then anterior interosseous nerve, that one comes from the median nerve. So that's going to be more on the flexor side, the anterior forearm. So anterior interosseous comes from the median nerve, and it's going to be deep muscles in the anterior forearm. Posterior interosseous comes from the deep radial nerve, and it's going to be the majority of the extensors down the length of the forearm. Okay? Posterior forearm. Okay. And I probably should have asked this because it would have been a perfect follow-up question. I don't know why I didn't think of this. But when you're talking about the anatomical snuff box, what is the major structure that he talked about that you can sort of palpate it, but mostly it's just going to be running through that space? What's the structure that goes through that? Yeah, radial artery. Yeah, so the radial artery, and he did say, yeah, Morgan, yeah, he did say that you can feel the scaphoid. So when you push on where the anatomical snuff box is on your hand, and by the way, a really good way to feel it is if you kind of just extend your hand out, like really extend your fingers. You can kind of see those two tendons actually start to stick out, and then you can feel the space there. And that if you push that space hard enough, you would feel the scaphoid. But then the structure that's running through it is the radial artery specifically. And he's gone over that many times. I would not be surprised if he asked about it, where it then emerges, because when you're looking at the anatomical snuff box, it's more or less it's really the lateral side, but it's on the dorsal aspect of the hand, sort of. But then the radial artery has to get to the palmar side of the hand. And so what muscle does it cross through in order to get to that palmar side of the hand? Yeah, it looks like you already said that. So thanks, Zach. So yeah, it's going to cross through that first dorsal interosseous. And the key there that I would say is make sure to specify dorsal osseous, not just interosseous, because you got those palmar interosseous muscles too, but it doesn't cross through that one. Yeah. Will, is that another name for it in case he actually puts that on the test? Radial foveolus, is that another name for snuff box? Yeah, okay, cool. All right, sounds good. So everyone take note of that. Apparently, I didn't know this, but radial foveolus is another term for that anatomical snuff box. But yeah, the major thing that he talked about was that yeah, and he did talk about the first lumbrical, but he also really hit that radial artery goes through that snuff box, crosses through the first dorsal interosseous, and that gives it access to the palmar aspect of the hand. Yeah. So when you're looking at the first dorsal interosseous, yeah, so it would be, the thing that he made sure to emphasize was that there are no dorsal muscles in the hand. So it was pretty much 4 layers, more or less, of palmar muscles. But when you're going through them, when you get to the deepest layer of the palmar muscles, you have the interosseous muscles. But considering they're the deepest, they'd be easiest to view through the dorsal aspect. And I think I actually have a picture of that and a question about that later on. But yeah, if you had a dissection like we have and you're looking from the dorsal aspect, it would actually be easier to see it there, but it doesn't mean it's a dorsal muscle. We don't have any dorsal hand muscles. It's just the deepest of the palmar. So it's closest to the dorsum of the hand. Okay, let's go on. All right. Which of the following statements is true? Yes. So first of all, let's pull up the slide on this next one. All right. Again, this came straight out of his lecture today. So got a few things here. The first thing, number 3, that's your rectus abdominis. One giveaway that you've got the rectus abdominis is all the fibers, at least in this picture, they're running left to right. So they're all going in the same direction. And then you have this tendinous intersection that's connecting the two different sections of that muscle. I don't know if he would ask specifically about this, but he's been known to be random, like on the last test. So here you got tendinous intersection. Here's 2 parts of rectus abdominis. And then one of the choices, which was the correct one, this one is rectus abdominis, the major movement is trunk flexion, okay? Antagonist to erector spinae on the backside. And then number 2, this is not deep fascia. So this is actually the tendon of rectus abdominis because it's a multi-bellied muscle. So here's one belly, here's a second one. So this, I think, is really more of an aponeurosis, but they specifically call them tendinous intersections in the case of the rectus abdominis. So this actually is not deep fascia. It's really just the tendon, one of the tendons of rectus abdominis. And then this one right here, I guess in real life, you'd be able to see which side is the head, which side is the feet. But the head of the person is over here on the right side of the image. And so that would make this the external oblique muscle. And just remember on this, when you're looking at external oblique, there's 2 ways to think about it if the head's over here on the right side. You can either think about it as the fibers, as they go inferiorly, they go medially, or if you go superiorly, they go laterally. So that would be, so because they're running in that direction, inferior and medial, that would be external oblique. And another thing, just in case he decides to be random and like put multiple choices that look the same, remember that the full name of this was external abdominal oblique. Last semester, he made kind of a big deal about that when we studied this for whatever reason, that you put the abdominal there when you're talking about the external and internal obliques. And then just remember that internal oblique is directly deep to this, but its fibers run in the opposite direction. So when you go inferiorly, they actually go laterally for internal oblique. And then deep to that would be transversus abdominis, which its fibers run perpendicular to rectus abdominis. And then the reason why some of these others were false, this one's not directly superficial to transversus abdominis. If it's the external oblique, it's directly superficial to internal oblique. So it would be 2 layers separated from transversus abdominis. And then this one, number 3, which is rectus abdominis, that one's not a component of that IST complex, which is like that thing that went around the thoracolumbar fascia with the multifidus, and it pulled on those contents in the spine, like ligamentum flavum, interspinous ligaments, all that. And it was like it's kind of like a weightlifter's belt, a natural muscular weightlifter's belt. And it braced the core, more or less. So there were only 2 muscles that he talked about that were directly a part of that because they inserted on the thoracolumbar fascia. And that was, the main one was transversus abdominis, but then he also mentioned internal oblique. There's a picture very early in Anatomy 1. You can go back and look at those. I assume everybody knows that you can actually still go back and you can look at all the stuff from Anatomy 1. If anyone wants me to show them how to do that at the end, I'll do that. But you can go back and see there's a picture where the transversus abdominis and internal oblique, they actually attach posteriorly on the thoracolumbar fascia. And so because they attach there, they're able to pull on it and brace the core from the back, front side going to the back side. Rectus abdominis, which is number 3, I think in this case, that one does not attach at all on the thoracolumbar fascia. It has its superior attachment on the xiphoid, and then its inferior ones on the pubis, basically, pubic crest and pubic symphysis. So let's go to the next one, see if we can get through some of these a little quicker. Number 8. Which of the following does not innervate the rectus abdominis? So that one was all of them. Half of the written. Can somebody, I don't actually remember, can someone answer, if you guys can see that Haley's question? I don't know if for the written part, which is I guess more lecture, more or less, is it going to be 50-50 with anatomy 1 and anatomy 2, or more of an emphasis? So less than half from 1, more than half from 2. It's nice that he said that, but that's, he didn't give a percentage, so that's still pretty vague. So yeah. Because for all we know, it could be like 49% 1, 51%. I would probably just, yeah, it's probably going to be 60-70, I would guess. Yeah, that's probably about right. It'll probably be a little bit more percentage than he normally does from the regular midterms, but it's probably not going to be more than half 1. So anyway. Okay, so on this one, so the rectus abdominis, when you look up its innervation in his PowerPoints, and it pretty much is the same for all of those muscles in there. So all 4 abdominal muscles, rectus abdominis, external and internal obliques, and then transversus abdominis, they pretty much all have the same innervation, if I remember right. And it's really all of these. Now in there, he says thoracoabdominal nerve. Make sure you differentiate that from thoracodorsal. So thoracodorsal is latissimus in the back. And also on the last practical that we had 7 weeks ago or whatever it was, he kind of jumped the gun. We went to, because we hadn't done the brachial plexus at that point. And he had a question on there about, thoracodorsal nerve coming from the posterior cord of the brachial plexus. So just remember, thoracodorsal is latissimus dorsi. But thoracoabdominal is in the front. And this innervates rectus abdominis and all the other 3 of those abdominal muscles. And the thoracoabdominal nerve is really just branches from the ventral rami of T7 to T11. So these 2 are more or less the same thing, because these ventral rami, they branch, that is from T7 to T11, and they form the thoracoabdominal nerve. So these 2 are more or less synonymous. But then it also has a little bit from T12. So remember, T12 doesn't actually form an intercostal nerve. The ventral rami from this form the subcostal nerve. And the subcostal nerve will also play a role in innervating those 4 abdominal muscles, but specifically in this question, rectus abdominis. So all 3 of these are technically correct. And that can be helpful, though, when you're trying to remember the innervation for the abdominal muscles. Just remember, they're pretty much all the same. I think in his PowerPoints, they may actually be exactly the same, but at least they're very similar. Okay? They've got all 3 of these. Okay, go to the next one. Number 9. If you're just joining, I don't know why it says multi-select. They're all one answer except for 1. This one is identify structure number 1. So this one was extensor indicus. So the other choices were basically extensor digitorum communis, extensor carpi ulnaris, and then extensor carpi radialis longus. So let's go to the next one. Here we go. So this was that one that had the weird hand. I think technically it was amputated. I think I don't remember, I think the 3rd digit was actually amputated, and then the thumb, if I remember right, was missing its distal phalanx, but you can still kind of tell everything here. So what I would do, if I knew I was looking at basically the dorsum of the hand and the posterior compartment of the forearm, one of the first things I would do is try to identify the extensor digitorum communis, because that one kind of gives you a landmark from which to go off of for the other ones. because that's the one in the superficial layer, at least, that it has a bunch of tendons that go to the various digits, right? So here's one tendon. Excuse me, that's not one. This one, this is one tendon of extensor digitorum communis. Here's another one right here. And I think he said that this one technically also was. It's just that since they had surgery to remove the finger, they rewired it basically. But then this one that's number 1, this one also is going to the second digit right here. But this one is not from extensor digitorum communis. This one, if you follow its tendon back, and he would probably, I would hope, would give a better view of this, but it kind of goes underneath this point right here on extensor digitorum communis, so it actually runs a little bit deep to that. And it's actually more on the ulnar side, because the thumb is over here, so this is the lateral side. The digiti minimi is over here, the pinky, so this is the ulnar side. And so the extensor indicus is really more on the ulnar side, and it's also a deeper muscle. But then it kind of comes out here, the tendon, and runs laterally toward the second digit. And probably if you had a different view of it, which I assume we will with the video, hopefully you'd be able to see that this tendon, if you follow it proximally, kind of goes deep to this muscle right here, extensor digitorum communis. Anybody have any comments on that or any questions? Or all right, cool. Next one should be a follow-up to that one, number 10. Identify number 6. Maybe it's not. Nope, not a follow-up. Okay. Number 6. Yeah, so that one is musculocutaneous nerve. So let me go to the PowerPoint for that. Let's see, where is it? Right here. So I think hopefully at this point, I think this kind of general structure right here, it looks like an M. That kind of gives you a clue that we're looking at the brachial plexus. And when you see that M, the middle one, which he may ask it, although he kind of likes to sometimes do the harder ones, try to do that here. This one in the middle is the median nerve, number 5. And we know that because it appears to be getting contributions from this side over here and then this side over here. And the two cords that it gets branches from are going to be the medial and lateral cords. And I guess the question would be, how do you know which one is which, given, because, you know, we'll obviously know which side's the head, so we can, I guess, more or less tell, and you can probably follow these nerves a little bit and see where they go. Let me actually see, I think I have the, maybe I don't, the brachial plexus picture. I thought yeah. So, so you got the lateral cord. You can see that up here at the top. And then the medial cord's at the bottom. Again, I think we still have to know all the branches that come off, all that. But then here you've got the contributions from the lateral cord and then also the medial cord right here. And they form that median nerve. And so the two that are going to run with it are most likely musculocutaneous or the ulnar nerve. Because in the picture, let me actually copy and paste this. In that picture, scrolling back up, yeah, so we can clearly see these two roots are either lateral or medial cords because they're giving the two branches that lead to that median nerve. So we know that's what these are. So this one, which is number 6, has to be either musculocutaneous or it has to be the ulnar, because it would continue on as that. So 4 would actually be the ulnar in this case, and 6 would be musculocutaneous. And the way I like to think about it is if you look over here, one clue is this nerve right here. So anyone want to take a guess what number 1 is? That I will be pretty upset if it's not on the test, given how much he emphasized it. Yeah, I can already, yeah, long thoracic. So this one is long thoracic. Also remember, it comes into the axilla with superior thoracic artery, which comes from the first branch of the axillary artery. Then it leaves with the lateral thoracic artery, which is from the second branch underneath pectoralis minor. But anyway, so here's long thoracic nerve. And you can kind of tell, because it's exiting here, that this must be proximal or superior on this side. and it's running down down the serratus anterior. So it would have to be inferior or maybe distal over here. So if you go back and look at this picture, the lateral cord is a little bit more superior, a little bit, because it's from the superior trunk, whereas the inferior trunk becomes the medial cord. So given that, this one, number 3, this one would have to be the lateral cord, because it's a little bit higher up. And then number 2 would have to be the medial cord, because it's a little bit farther down, a little inferior. And then, so that makes number 6 musculocutaneous, because that comes off of the lateral cord. Number 4 is probably ulnar nerve. And then in terms of the other 2 choices, which I believe, yeah, there was axillary nerve, and then I could have also thrown in radial nerve, excuse me. Those ones we probably couldn't see too well in that picture, because remember, axillary nerve, radial nerve, they're branches of the posterior cord. And these cords are, remember, they're named according to their orientation to the axillary artery. So the axillary artery is underneath this, most likely. And so the posterior cord would be posterior underneath that. So we probably couldn't see axillary or radial too easily here. So number 6 would be musculocutaneous. So just remember, you can often differentiate those two, the lateral cord and the medial cord, because the lateral one comes from the superior trunk, so it's going to be a little bit more superior than the medial cord, which is going to be a little bit more inferior. And then that can allow you to deduce whether it's musculocutaneous or ulnar. Okay. This next one's going to be a follow-up to this, I believe. It's about musculocutaneous nerve. Yeah, what muscle is innervated by musculocutaneous nerve, in other words? Yeah, coracobrachialis. So for this question, so we can run through the 3 muscles that are innervated by the musculocutaneous. Remember, musculocutaneous really only innervates things in the brachium, anterior brachium. So there's 3 muscles there. Probably the more obvious one is biceps brachii, both heads. And then you've got brachialis, which is directly deep to biceps brachii. And then you've got coracobrachialis, which is running from the coracoid process of the scapula, and then it kind of inserts roughly halfway down the humerus on the medial side. So those 3 muscles, those are the ones innervated by musculocutaneous, because those are the 3 in the anterior compartment of the brachium. But these others, so like teres minor, that one was axillary, based on the previous question. So axillary, remember, has 2 major muscles. You got teres minor, and then you got deltoid, right? Teres minor and deltoid for axillary. Serratus anterior, that was innervated by long thoracic. And then opponens pollicis, this was going to be not directly, but it's a branch of the median nerve. So when you get down to the hands, there's only 2 innervating nerves there. And you more or less can just think about it as the thenar muscles. There's 3 of them. Thenar muscles would be the ones that control the thumb, but they're intrinsic to the hand. So you've got abductor pollicis brevis. You've got flexor pollicis brevis, and then you've got opponens pollicis deep to that. Those 3 thenar muscles and the first lumbrical are all going to be innervated by the median nerve, specifically a recurrent branch of the median nerve. And I like to think about it, if you basically take the hand and kind of draw a line right down the middle of the 2nd digit. Everything on the pinky side of that is going to get innervated by the ulnar nerve, and everything on the thumb side of it's going to get innervated by that median nerve, or at least a recurrent branch of it. And so the thenar muscles are on the thumb side of that line that goes down the 2nd digit, so they're going to be median nerve. And that first lumbrical is kind of on the thumb side of the 2nd digit, so it's still kind of in that area. So I like to think of it that way. But opponens pollicis is a thenar muscle, so that would actually be median nerve there. Okay, let's see what we got. Yeah, recurrent branch of the median nerve, right? All right, let's go to the next one, number 12. let's see, number 2. Yeah, so that one is rectus capitis posterior major. So let's go to that. So here, I was trying to actually show that we got the suboccipital triangle right here. Although to be fair, when we're looking at it on an actual cadaver, you'd be able to see that it's kind of right, at the base of the occiput on the back side of the neck, so posterior neck. So you'd at least be able to see that. And when you're looking at it, if I can kind of move this out of the way for just a minute, it's kind of a nice thing here because you've got this almost like an X right here. So you've got one branch of the X going like this, one going like that, and then 2 that are going down like this. And so put that back there, that little blue circle, that's the C2 spinous process. These 2 muscles down here, left and right, these aren't part of the suboccipital triangle, but again, he did go over them. So the semispinalis cervicus actually inserts up there on the C2 spinous process, and they form kind of this bottom 2 branches of the X. And then the upper 2 branches are actually, I think the one of them that I asked about is this one right here, which is rectus capitis posterior major. And then you've got a couple others that make up the triangle. There's the one right here, which makes up, I guess that's the lateral, like superolateral boundary. That one would be obliquus capitis superior. And then this one, which is the inferior boundary, would be obliquus capitis inferior. Remember the 2 rectus capitis muscles are both the medial ones. So this one that actually makes up the boundary of the triangle, suboccipital triangle, that one is rectus capitis posterior major. But the one directly medial to that, which is a little bit shorter, that's your rectus capitis posterior minor, right? And remember that minor doesn't actually constitute a boundary of that triangle. So it's only these 3 right here. And then this muscle down here, which is attaching on that C2 spinous process, semispinalis cervicus, this one isn't part of the triangle either. In fact, that was actually covered in the back muscles. This would have been one of the transversospinalis muscles. And it just happens to insert there to kind of form this X, so to speak. Or if you even count the obliquus capitis inferior, it kind of makes a 6-sided star or something like that. But anyway, I still think it'd probably be a good idea to know kind of these origins and insertions. Remember that you've got 3 here that are inserting on the occiput. So all 3 of these up here, rectus capitis posterior minor, major, and obliquus capitis superior, they're all inserting on the occiput, so the base of the skull. But just remember the obliquus capitis superior is most lateral, minor is most medial, and then major is kind of inserting somewhere in between. And then obliquus capitis inferior doesn't attach on the skull at all. It just goes kind of laterally to make up that inferior boundary of that triangle. So, and then there was another structure this really big nerve. It kind of goes through it goes over the triangle, not really through it. It goes over it. That one was the greater occipital nerve, right there. And then there's a follow-up question to this, based on the suboccipital triangle. This one has 2 answers. This one does. Name the 2 major structures found in the triangular region, suboccipital triangle. Yes. So he likes to do this kind of stuff where he says vertebral artery and nerve, artery, and like mix them up. But yeah, so there's an artery and there's a nerve that goes through this. So in terms of the suboccipital nerve, not only does that nerve go through it, but all 4 of these muscles that make up the triangle, or at least that make up the region. So the obliquus capitis muscles and the rectus capitis posterior muscles, all 4 of those are innervated by that suboccipital nerve. And then remember that also there's a vertebral artery. So you've got one artery and then one nerve, suboccipital nerve and then vertebral artery. So remember that vertebral artery, and this is one of those things he also threw on a quiz, he threw it on an exam, it was on the last exam too. I bet it's gonna come up again. You have that picture of the cervical vertebrae, and you've got the vertebral artery that enters the transverse foramen at C6. So it doesn't enter it at C7, it enters it at C6 and then kind of goes up, and it loops around when it gets to C1, C2. And then as it's looping out of C2 and ascending upward, it goes through this suboccipital region right here. So you would theoretically, I think actually this right here, that little vessel right there, that actually should be, I think, the vertebral artery. It's just been cut. But those are your two contents of that, vertebral artery and suboccipital nerve. But I just brought up that thing that he's asked about on several quizzes and tests, and then this last test is he mentioned in the sync session today or yesterday or something that that we missed carotid tubercle. Carotid tubercle, there's carotid sinus, they're kind of all in the same question. But definitely make sure you go back and look at that. And in terms of the carotid tubercle, basically my understanding is there's basically, if you look at the C6 transverse process that has the transverse foramen, there's a couple bumps on that. There's like an anterior bump and a posterior bump, and I'm blanking on which one it is. You could probably just look up carotid tubercle. I can't remember off the top of my head, but one of those bumps on the C6 transverse process, that is the, should be anterior, yeah. So it's anterior. So that's the carotid tubercle that he keeps talking about. And it's not on all of them. It's only on C6 for whatever reason. And I think the reason for that is that he mentioned this in another thing today. He had a slide, or not a slide, but he had a segment where he had the common carotid artery, and he moved it over, and there was a muscle underneath, a really, really deep anterior neck muscle. I think it was longus colli. And there was a longus colli muscle, and if you push, just basically push on that region, you basically could palpate the carotid tubercle. I don't know if he's going to get that specific on that, but just make sure you go back and take a look at that stuff because he's had it on several things. Suboccipital nerve, C1 or C2? Anyone actually answered that? I don't actually know that off the top of my head. I don't know if he ever mentioned that. We got C1, C2. Want to take a look at that real quick? Let me just see if I can pull it up on my phone. Let's see, suboccipital. Yeah, greater is not C1. I think greater is C2 and C3. Suboccipital nerve. Let's see if I can get something real quick on that. Suboccipital, yeah, C1 is what, if you just look up suboccipital nerve, it's the dorsal primary ramus of the first cervical nerve. So yeah, it's going to be C1 in that case. So anyway, let's go on to the next question here. Identify structure number 2. So switching regions down to the lower body. Yes, adductor longus. So let me go to that. I think I got something on. That's not the right slide. Maybe it's a few on it. Yeah, here we go. Yes, I didn't put the numbered one in there. In any case, so several choices there. We've got, first of all, structure 2, pectineus, adductor longus, gracilis, and adductor brevis. So when you're looking at this, when I personally look at this, I like to find, first of all, I like to find a couple muscles. One, I like to find sartorius. That's one of those that I hope he asks. It's one of those not too difficult. I also remember sartorius is like the seatbelt muscle because it kind of crosses over some of these muscles like rectus femoris, some of the adductors like a seatbelt almost. So I remember it that way. And then here, that really thin muscle that goes all the way down to the pes anserine tendon, the gracilis. Because once you find those, you kind of just work your way in, and it gives you pretty much all the adductors. So if you work your way in from the gracilis medially, you've got adductor longus. And then remember that adductor brevis is deep to this, adductor longus. And then up here you have the most superficial or most superior one. This one is pectineus up here. So you've got pectineus, adductor longus, brevis is deep to that, and gracilis is right here. And then magnus is really kind of deep to both gracilis and longus. But remember, magnus goes all the way down. It'll insert on the femur up here, but it goes all the way down, basically to the tibia, or excuse me, not the tibia, the very distal aspect of the femur. Because remember, on the femur, on the medial condyle of the femur, there's a little bump there that was at the adductor tubercle. And yeah, Jeremiah said the adductor tubercle. And so there's two parts of the adductor magnus, which we'll come to in a minute. But he asked that on the last practical. And when we get to that, I'm going to poll you guys and see if you guys remember what the question was, because I'd really like to remember exactly what it was and get it on a recording. Something about the adductor magnus. There's a vertical component, and then there's an oblique component. But anyways, we'll get to that. But yeah, this one, the answer to this question was adductor longus. And remember, that's one of the three major superficial adductor muscles. Let's see. Brevis wasn't even visible in that picture. So, number 15, follow-up question. Which of those muscles, pectineus, longus, brevis, or gracilis, often has dual innervation? So two nerves often innervated. Yes, pectineus. By the way, just for you guys, just so you know, I can actually go a little bit longer today. So I'll actually go until 7 o'clock. So if you guys want to stay on, I know normally I only go an hour and a half, but I'll stay on for another hour. So so don't worry about it. We'll probably finish all of this. So. Okay, which of those muscles has dual innervation? So one of the things I think we ought to remember is that when you get into the thigh, so you got 3 compartments, right? You've got an anterior compartment, which is your quadriceps. You've got posterior, which is hamstrings, and then the medial part is the adductors. And so remember that all of those have a pretty much a unique innervation. So if you go to the anterior compartment, the quads, pretty much femoral. And I think actually, yeah, it's unanimously femoral nerve. And also sartorius is femoral nerve. Then if you go to the hamstrings in the back, posterior compartment, they're all sciatic nerve. And then the the adductors, they're generally all obturator. But there's 2 exceptions in the adductors. And one of them is here, is the pectineus. The way I rationalize it, I guess, is because the pectineus, if you look at its position, it's kind of closer to the quads. So here's rectus femoris right here. That's one of the quads. Here's sartorius. Those are both innervated by the femoral nerve. And then here's pectineus, and then here's the rest of the adductors. So the pectineus is kind of right between the adductors, which are innervated by obturator. And then it's also right next to the anterior muscles, which are innervated by the femoral nerve. And so for that reason, pectineus is going to have 2 innervations. And I believe it's the medial half of it, or medial 2/3 roughly, I don't think we need to worry about that too much, is obturator like the rest of the adductors. And there's a little part of it laterally that's innervated by the femoral nerve, which makes sense because the femoral nerve is actually right over here. And another thing also, while we're on the slide, to also remember that when you're looking at this area, so we would have our inguinal ligament somewhere over here, right? And remember that up here would be the external carotid artery. And so remember, when the external carotid artery crosses underneath the inguinal ligament, it changes names to this artery, which is the femoral artery. And then the vein goes the opposite direction. So coming up, it's the femoral vein. And when it crosses under the inguinal ligament going up, it becomes the external iliac vein. And then remember that you can remember the order of these, just it's like a VAN, V-A-N. So vein, artery, nerve. And then the other things I thought it was external because internal goes really more into the pelvic the pelvic cavity. Can anyone verify that? But I thought it. Well, it's external iliac because we're all the way down in the legs. Did I say external carotid? Oh, I apologize. Sorry, been a long day. So yeah, I meant to say an external iliac artery. So sorry if I confused anybody about that. Yeah, and yeah, the internal iliac is in the pelvic cavity in here. And so the external iliac goes over here, crosses underneath the inguinal ligament, and then becomes the femoral artery right here. And then also remember that that femoral artery has that branch that comes off of it pretty quick, which is that profunda femoris artery, or the deep artery of the thigh right here. And it's deeper than the femoral artery right here. And then you've got here the femoral nerve and then the femoral vein. And the other stuff that I would focus on remembering is also we've got the femoral triangle right here, remember? So you got a triangle where the superior part of it's the inguinal ligament, the medial part of it's adductor longus, and then you've got the sartorius as the lateral boundary that make up that triangle. And then you can see all these structures that are in here. You've got the femoral vein, V, you've got the artery, and then the nerve, van. So all three of those structures are in that femoral triangle. And I guess you could say profunda femoris artery is also. But then remember that there's only a few of those structures that are actually in that sheath. So this whole thing is the femoral triangle, but then the nerve, femoral nerve, is not actually in the sheath. And someone actually brought this up, I don't remember in that, I think in the sync session. Remember that the femoral sheath, you've got the artery, you've got the vein, and then there's the lymphatics in the canal, as I understand it. And in this picture, you can see that sheath right there does not include the femoral nerve. And then also remember, this was something he asked about in a quiz, I think. Remember that great saphenous vein? That's kind of like in the leg. I think the great saphenous vein went down the lateral side, so it would function in the arm like cephalic vein. Cephalic vein is the superficial vein on the lateral side of the arm and forearm and hand. So the great saphenous vein is like that, but it's superficial. So in order to dump back into the femoral vein, it has to penetrate this fascia, right? And that penetration right there, he had several names for it, but one was actually, I think, fossa ovalis. I think fossa ovalis was one name he gave for it. I looked it up on Wikipedia that day, and it was also called saphenous hiatus. But just remember that it has to cross up there through that fascia to gain access to the femoral vein to drain back into the, up here it would be external iliac vein on that one. So again, make sure you go back and look at those boundaries, what's in the sheath, what's not in the sheath. And this was also a picture that I found kind of useful. I found it on Teach Me Anatomy. It's a good website on you can just Google Teach Me Anatomy. It has a bunch of stuff on there. But he asked about this on the test that we were tested over this in Anatomy 1, and I just guessed on it. I guess I was lucky. But if you look right here, so here you've got this would actually be, I think, the femoral, let's see, here's the vein right here. Here's the femoral canal. So this should be, I think this should actually be the artery right here. But anyway, this segment right here in kind of orange was the lacunar ligament. And he asked about that on the test, and I kind of just guessed on it. I guess I didn't study that. But remember the lacunar ligament, if you look at this ligament, it's actually medial to the femoral canal, which is then also medial to the femoral vein. So you can kind of learn it if you go back to, let's see, this right here. You've got the vein, the artery, and the nerve. But then before that, on the other side of the canal, you'd have the lacunar ligament kind of right over here. So just thought I would bring that up just in case it comes up on the test or whatnot. Okay. So got off on a huge tangent there, but I thought it'd be useful to go over. But yeah, pectineus is one of the adductors that has that dual innervation. So it's mostly obturator, just like the other ones here, but it also has a little bit of femoral innervation. And then remember, adductor magnus, the other adductor muscle, is a really big muscle. So it also has dual innervation. It's obturator also, because it's an adductor. But the part of the adductor magnus that's close to the hamstrings, it shares the hamstrings innervation, which is sciatic. So make sure to remember that there's two muscles there in the adductors that have dual innervation. These three, as far as I know, are just one nerve obturator. So let's go to the next one, number 16. Number 2. This one might be hard to see. Yeah, so this one was the superior gemellus. That one was kind of hard to see. So let me actually go to that picture. Where is it? That's similar. That's not the same one. Well, this one's the same picture, so we can actually zoom in on this. First of all, before we zoom in, so in this case, over here, this muscle on the far right of the picture, that's gluteus maximus. So that's already been cut and it's been folded over. And then gluteus medius is up here, also been folded over a little bit too. And so now you've got in here the deep gluteal muscles. And so these are going to be all those hip external rotators. I actually put them right here. So you've got basically 5 muscles right here, and they literally all do the same thing for the most part. They're all going to facilitate hip extension, not strongly, because remember, hip extension is mainly gluteus maximus. They can assist with that. Their main job is lateral or external rotation of the hip joint. So I should probably just underline that. It's mainly the lateral rotation of the hip. And there's 5 of them. And these are really useful to learn in order, I think, from superior to inferior. Because if you learn them that way, the nerve innervations are kind of grouped. So on the top, you've got piriformis. This muscle, I think I have another thing, we'll see it later. But remember, piriformis actually has to come through the greater sciatic foramen right there in order to gain access to the gluteal region. And remember that piriformis actually originates on the sacrum. So none of these actually originate on the sacrum. This actually has to go through that, this is the greater sciatic notch, I believe. And then it runs through here from the sacrum and then inserts on the femur. And so that way it's actually able to facilitate lateral rotation. All these other ones, they originate on some part of the pelvis for the most part. But the point is that they're grouped nicely. So on top you have piriformis. And then you can look at it this way, you've got the tendon of obturator internus that's flanked by a gemellus on either side. So if you find the tendinous part, which is going to be really white, because the tendons are white, if you look on either side of that, there should be some small muscles, and those are the gemelli. So on top, you got superior gemellus, and then on bottom, inferior gemellus. And then there's a really large muscle, which is kind of nice because in the pictures, it's actually kind of not too big, but then when you look at it on the cadaver, it's pretty large. That was quadratus femoris. And so if you kind of learn them in order like that, it makes sense because you can group them according to the nerve. So piriformis, kind of unique because it's actually coming through this. So it gets its own nerve to piriformis. And then the next 2 in order, so you've got superior gemellus and obturator internus, they get nerve to obturator internus. And then the next 2, this one is inferior gemellus and quadratus femoris, they get grouped together, nerve to quadratus femoris. And then for these 4, you just have to remember that the nerve is not named for the gemellus. It's named for the other one in the group of 2, so to speak. So with that, going here, I'll zoom in. This one, this larger one on top, this would be your piriformis. And then if the next step I would do is you can find the tendon of obturator internus. This structure looks pretty tendinous, so that would be its tendon, obturator internus. Also has to be below piriformis. And then the 2 muscles that flank it on either side would have to be the gemelli. So the one on top of the tendon of obturator internus would have to be superior gemellus, and the one on bottom would have to be inferior gemellus. And then this bulky muscle, well, relatively speaking bulky, down here, that would be the quadratus femoris. So that gives you those 5 muscles right there. Yeah, terrible. Princes get on good-looking queen. Oh my. let's see, anterior tibial arteries in the hip. Let's see, anterior tibial artery. Doesn't the, see, I got to go back and look at stuff too. Do I, oh my gosh. That was probably left over from another slide I was labeling. I apologize for that. Yeah, anterior tip, that's not in the hip. Yeah, I must have had that left over from a previous slide or something like that when I was making these. Yeah, so yeah, no anterior tibial artery. That's not down until, that comes off of popliteal artery, am I right? Because you have the popliteal artery on the back side of the knee, which then branches into anterior, you get an anterior tibial artery, and then I believe you also get a posterior tibial artery off of that. And yes, and the anterior one will go through the interosseous membrane to supply anterior compartment of the leg. Yes, I gotta go back and look at that stuff too. So yeah, and then the other thing I wanted to look at here also were just the big gluteal muscles. So just remember that glute max is mainly innervated by the inferior nerves and vessels. So that means inferior gluteal nerve, inferior gluteal artery and vein and stuff. And then the other two, glute med and glute min, those get the superior ones. And also remember the way they're named is they exit through here on greater sciatic foramen. But remember that if it exits above the piriformis, so coming out of this tiny hole right here, those would be the superior vessels and nerves. And then if they come through the bottom of piriformis underneath, it'd be the inferior gluteal nerves and vessels. And I don't know if this is super important, but glute max, it's mostly inferior. It does get a little bit of supply from the superior structures, a little bit, but the vast majority is going to be that inferior nerves and vessels. And also, I don't have it here, but tensor fascia lata shares the same innervation as glute med and min. So tensor fascia lata also has superior nerves and vessels. Yeah. Yeah, thanks, Pius. Yeah, so TFL, tensor fascia lata, is also superior nerves and vessels there. Okay, so let's go on to one of the next one. Number 17. Let's see. Oh, what nerve innervates structure number 2? Which I guess was superior gemellus. Yeah. And again, that's kind of back to that grouping of some of these. If you learn them in order like that, that can also help you identify them. But when you group them like this, you can, or when you order them like that, you can group the nerves. And so superior gemellus is grouped with obturator internus, so they get the nerve to obturator internus for their innervation. So, okay. So let's go to number 18. Identify structure 3. That's this one right here. Yeah, so this one is, now there's two names of this one that are basically the same. So this is ischio-coccygeus. That was the answer there. Remember, this one is also just called coccygeus. That can be confusing because there's also an iliococcygeus, which is part of levator ani. So before we do this, maybe we should say the 3 muscles that are part of the levator ani group. So you've got the puborectalis. That's the one that forms the sling around the rectum, which I don't think we'll be able to see too well. But you've got puborectalis. Then you've got pubococcygeus, and then iliococcygeus. So those 3 are going to be levator ani muscles. The other one, which is not part of those, it's separate. It's not iliococcygeus. It's either ischio-coccygeus or just coccygeus. So just be aware that he might be able to use either one of those names. And someone, one of the group chats, and someone said something. I was just wouldn't really paying too much attention, but they said, "Does anyone remember any annoying questions that Dr. P asked?" And I do remember one question that's been a while since we've seen it. He had a question something like, which of the following are the major muscles that make up the pelvic floor? And he was pretty adamant that technically, ischiococcygeus is not one of the muscles that makes up the pelvic floor. That the ones to go with are levator ani. I don't know if anyone remembers that from the last part of this anatomy 1, but he asked that on the final, and then he asked it on one of the tests. So levator ani are the main muscles that make up the pelvic floor. Ischiococcygeus is not one of those that actually makes it up, I guess. Does anyone remember that question? Or am I thinking crazy? Anyone else remember that? Let's see. Yeah. Yeah. So he definitely asked something like that. So if he has a question about what makes up the pelvic floor, it's levator ani. And yeah, so thanks, Taylor. So yeah, the most important muscles in the pelvic floor. That may be how he worded it on the test. But yeah, levator ani. And remember, these are innervated by nerve to levator ani. And technically, coccygeus is also. So all 4 of these, levator ani, these 3, and coccygeus, those muscles are innervated by that nerve to levator ani. And I had trouble finding a good picture of this. Let's see, this is it. Yeah, I had trouble finding a good picture of this online. This is the best I could do. So in this picture, so here's the sacrum over here. Coccyx would be down here somewhere, right? The way I'm just kind of thinking about this mentally is I kind of try to orient myself with roughly where the muscles are, because they kind of looked all fused. It looks like a bunch of meat there. And so it's kind of hard to tell exactly where one starts and one finishes. The way I'm kind of thinking about it is, if you're looking at kind of the base in the midline, because we're looking at what is that? That's a sagittal section, mid-sagittal section. So if you're looking kind of in the midline, that's more or less where you have levator ani and coccygeus or ischiococcygeus. So coccygeus is, if you're in the midline, coccygeus is closer to the coccyx or the sacrum. And then levator ani is more anterior. It's further away from the sacrum and coccyx. And another thing this is another question he had, which I could see being more on the, actually I could see it being on either one, probably more the written final. But he had a question one time of what's the attachment of the coccygeus? And he put both sacrum and coccyx as choices. And it wasn't like an A and B or something like that. And I believe that even though it's named coccygeus or ischiococcygeus, that it actually attaches on the sacrum. Anyone want to dispute that? But I'm pretty sure that even though it's named coccygeus, it doesn't actually, or the main attachment's actually on the sacrum. And I swear he had a question like that before. You can see what you guys are saying. Yeah, sacrum. Yeah, looking at his slide. Yeah, okay. So yeah, don't be fooled if he asks something like that. Coccygeus is not on the coccyx. It's on the sacrum, and then Jeremiah says also ischial spine. Thanks. Yeah. So coccygeus more posterior in the midline. Levator ani more anterior in the midline of the pelvic floor. And then you've got the walls, kind of the lateral sides. That's the other muscles here. So the one that's more or less anterior, like this one was obturator internus. And then kind of over here, a little bit more in the back, that's piriformis. So again, on the walls, so not in the midline, but kind of as you're going up like a bowl on the sides, that's more where you have obturator internus, and then you would have piriformis back here a little bit. So on this question, well, I guess it was ischiococcygeus. It was pointing right here. Yeah. Okay. Any comments there? Any questions? We go on. And by the way, you guys have been really helpful with this. I appreciate all the input you guys are doing. So thanks a lot for that. Yeah, Zach says levator ani muscles insert on the coccyx. Okay, yeah. It's kind of backwards, I guess you could say, at least the way I'm thinking about it, because coccygeus is on the sacrum and ischial spine, but sacrum, and then levator ani actually has some insertion on the coccyx. So make sure to keep those things straight if he pulls one of those on the exam. Okay, next one, number 19. What nerve innervates number 3? So ischiococcygeus. Yes, this one. So I don't know. This will probably be, when I'm studying tonight, this will probably be one of the last things I do, although wouldn't put it past them, is to go back and look at the lumbar plexus and sacral plexus, and then and to kind of just go back and see if we can remember the various branches of that and the different divisions. But nerve to levator ani, if you go back to the pelvic floor, it says specifically S3 to S4, so it does not include S2. I don't know how picky he's going to be on certain questions, how nitpicky, I guess, but it does not include S2. On this one, obturator nerve is not the answer, but for obturator nerve, this one is L2 to L4. That would, if this was asking about, let's say, adductor longus, maybe, this would be the answer because obturator nerve is L2 to L4. Obturator nerve doesn't really do much in the pelvic cavity. It goes through it and then exits the obturator canal and goes down to the leg where it innervates the adductors. So nerve to levator ani was more what does it, things in the pelvic cavity on the pelvic floor. All right, let's go to the next one. Number 20. Structure number 3. That's this one right here in my mouse is. You guys can't see that. A little small. Yeah, so this is one of the questions that I was going to ask you guys about because I honestly don't remember because obviously we don't get tests back. He asked something like this in the lab last semester when we went to immersion. I swear there was something. It was the adductor magnus, and there were, I don't know if he put vertical part or oblique part. There is no transverse part, so that's nothing. And so it was something representing the vertical part, which is the hamstring part. Because if you're looking at the adductor magnus, the vertical part is the most medial, and it's going all the way down to that adductor tubercle at the femur. Yeah, he did ask. Yeah, he asked about innervation, and it was a two-parter, as I remember, because he had one question on, and I think I missed them both, because the first question was something about, I could be wrong, but I swear it was something like this, where he had adductor magnus, or he had the vertical part, he had the oblique part, and then he had like all of the above or both of them. And I don't remember what it was. But I want to say that it might have been the vertical part, because the vertical part, like I said, that's what's the more medial part. If you're looking at the legs, it's going down the midline, and then it's going all the way down vertically to the adductor tubercle, which remember is on the medial condyle of the femur. So it has, in order to go from the pelvis down to the femur all the way down to the bottom of it, the adductor tubercle, it pretty much has to go vertically. So that tells you the vertical part. And that part is the hamstring part. So that's the part that will assist with the hip extension part of the hamstring functions. And so because it shares a hamstring function, it would be sciatic nerve. The oblique part is much bigger. That's the part that goes from the pelvis all the way, kind of going obliquely to different parts of the medial femur, but not down to the adductor tubercle. And so that part's the actual adductor part, where it would adduct the hip back in. And so that would be obturator nerve. And then remember that there's that hole in the middle, like that separates the vertical part from the oblique part, and that's the adductor hiatus. So remember, we looked at one of those slides earlier with the femoral triangle. So when those vessels and structures go through, when they get to the bottom of the triangle, they enter the adductor canal, which is in the adductor magnus, and they go down it and they exit through that hiatus, which is that space in the tendon between where it separates the vertical part from the oblique part. I don't remember the question exactly, so I don't want to say, you know, put this or whatnot, but I feel like if it's on the medial side, then it's got to be the vertical part, and the vertical part is the hamstring part, so it's sciatic. If he had something that was more laterally placed, I guess, and especially further up the thigh, if the fibers are going diagonally, that'd be oblique part, and that's the adductor part, which is obturator. So I don't know exactly what the question was, but if anyone, if I guys might send a message out, if anyone remembers what it was, wouldn't mind sharing that, because I missed at least one of them, I think, on the practical last time around. The other thing that might be useful, I don't know, is when you're talking about the hamstring parts, because the hamstring does two things. Yes, which part of the sciatic nerve innervates the hamstring portion? Is that what he asked? So the sciatic nerve has two parts. It would be the tibial branch, and then the common perineal branch. Ooh, I have to go back and look at that. Is it common perineal for the adductors? Okay. Well, I know he has something on that in his PowerPoints. I think he does. I know I have something somewhere on my computer. I'll look for it after we get off here. Maybe I'll put it in the PowerPoint before I post it. The perineal part is lateral, and then the tibia is, let's see. Well, in any case, I'll go look at that. I have something on it as well, and I'll post something in it on the PowerPoint in the Facebook post. That is the tibial portion of the sciatic nerve for the adductor magnus. Yeah, that probably is what it is. Yeah. Okay, so it's tibial. So for the hamstring part, we'll go with tibial on that of the sciatic nerve. Okay. All right. Thanks, Rachel. Thank you. Okay, but the other thing I was going to mention about it is just remember that the vertical part is inserting on the adductor tubercle, so all the way down on the medial condyle of the femur. So it's not actually crossing the knee joint, which is important to remember, because if he's asking about the functions of it, let's say this time around, the hamstrings do two things. The true hamstrings, they do knee flexion, and they do hip extension. But in order to do knee flexion, you have to either attach on the tibia or the fibula. You have to cross the knee joint to do knee flexion. So when they're talking about it being a hamstring part of adductor magnus, they're only referring to the hip extension, because it doesn't cross the knee joint as far as I know. It just is able to extend the hip like the hamstrings, not flex the knee. So just thought I would bring that up. But yeah, thank you guys for the input on that one. All right, number 21, next one. What constitutes the major innervation of structure 3? So same kind of thing. Yes, and yeah, so if we're specifically talking about the hamstring part, so from the previous part would be the vertical part of the adductor magnus, then that would be the sciatic. The rest of adductor magnus, which is the oblique part, that would be your obturator nerve, which is what the rest of the adductors are innervated by. And according to Rachel, and I think that actually sounds right, you got the sciatic for the tibial branch of the sciatic. Because remember, the sciatic, as it's going down the thigh, it's in that sciatic sheath, and you have two parts. You have a tibial branch, which is a little more medial, and then you have the common perineal or common fibular, which is lateral. And once they get really to the superior angle of the popliteal fossa, they bifurcate. The sheath terminates and they separate. So you have a medial, slightly more medially placed tibial nerve, and then the laterally placed common perineal. But while they're in the sciatic sheath, they're together, but they still have branches that go off. And I think the adductors, or excuse me, the hamstrings, for the most part, are going to get the tibial part of the sciatic. And so that means that if they get the sciatic tibial branch, then so too would the adductor magnus vertical fibers. The one thing I would say is that if you're looking at biceps femoris, it has two heads, right? It has a long head and a short head. The long head goes all the way up to the ischial tuberosity, whereas the short head doesn't go up that far. It just goes up to somewhere on the femur. If you look at the biceps femoris of the hamstrings, the short head is the only exception to the tibial rule. So all the hamstrings, they're all sciatic, right? Every one of the hamstrings is sciatic nerve. All of the hamstrings, except for the short head, get the tibial branch. I believe that the short head of the biceps femoris actually is common perineal. I don't know if he ever went over that, but I remember seeing a picture at one point where common perineal is actually the short head of the biceps femoris, but all the others, including the long head of it, those are going to be the tibial branch of the sciatic. So just some food for thought there. All right, next question, number 22. Identify number 2. Yeah, so 2 mylohyoid. So let me go to that one. These might be out of order. So here we go. So here's the hyoid. I always find that, I don't know about you guys, most people probably have this strategy. Finding the hyoid bone is probably the best place to start once you kind of know which area you're looking at. So here's your hyoid. Suprahyoid muscles are all up here. I kind of, when I look at it, I see the 2 digastric muscles, and it's specifically the anterior parts of them. So the anterior belly of digastric right up here. And then kind of this muscle that spans all of this in here would be mylohyoid. Also, just another thing to remember, this one, number 7 right here, this tendinous intersection, so to speak, between the 2 halves of mylohyoid. So that was another one of those raphe that he had, median raphe. So make sure to remember that one. Yeah, excuse me, median raphe. And then, of course, right below that, you've got the hyoid bone. I don't know if it's actually visible here. It might actually be this muscle, not sure, but there is, remember, there's also a stylohyoid in there somewhere. So it's going from the lateral sides of the hyoid up to the styloid processes. So remember that, you've got stylohyoid as well. Anyway, so that's mylohyoid. Geniohyoid, that was listed, I think, in his PowerPoints. I think it was. But geniohyoid you wouldn't be able to see. And that's just because geniohyoid is, it's deep to mylohyoid. You'd have to completely remove this, and probably most of the digastric, you'd have to remove it to actually see it, geniohyoid. So, follow-up question. What nerve innervates structure 1? So this is actually number 1 this time. So there's this muscle up there at the top. Yeah, so on this one, remember digastric. So this one is digastric. The one that's coming off of the mandible, which you can see up here, that's your anterior belly. And then it has a tendinous sling that goes around this intermediate tendon. And that tendinous sling, remember, is coming from the hyoid. In fact, I think you can actually see it there. So off of the hyoid right here, you've got a tendinous sling that's going to kind of wrap around that intertendinous part of the muscle. So here's your anterior belly, and then somewhere back here, we can't see it, would be the posterior belly. And remember that for digastric, the innervation is different. So for the anterior belly, you've got the trigeminal nerve. So remember trigeminal nerve that was cranial nerve 5. It had the 3 branches. Might be worth it just to mention those. So 1 was ophthalmic, and you got 2, which is maxillary, and then 3, which is this one, is mandibular. This is mandibular. So that's going to be your anterior digastric. And then this one, that is, my apologies, that was actually supposed to be cranial nerve 7. I must have typed an extra 1. But if it was 7, cranial nerve 7, the facial nerve would then get the posterior belly of digastric. So remember, that's the muscle that has dual innervation. One way you could, I guess, think about it is if you anterior comes before posterior, so cranial nerve 5 comes before cranial nerve 7. So if you want to think about it that way, that might actually help keep them straight which one's which. But if you're looking at which of the trigeminal branches for 5, it makes sense that it's the third one, the mandibular, because you're at a structure that's at the mandibular level. It wouldn't be maxillary, that'd be way up here, and then ophthalmic is way up by the eye. So it has to be the third branch. So I don't know if that helps anyone, but that can help you keep it straight. And then posterior belly, posterior is after anterior, so cranial nerve 7 is after 5. So facial is actually the posterior belly. And then also it might be worth mentioning that from the previous question that asked about mylohyoid, mylohyoid's innervation, it's specifically nerve to mylohyoid, but the nerve to mylohyoid comes from the mandibular branch. So the mandibular branch also gives off the nerve to mylohyoid. So it actually innervates both of those. It innervates the mylohyoid and then also anterior belly of digastric. Okay, let's do the next one here. Number 24. Number 10. This muscle right there. Yes, sternothyroid. So on this one, so a few other features here. So same picture, we already identified the hyoid bone right here. So now we're into the infrahyoid muscles, and there's really 4 of those, right? So over here, these ones, they go up all the way. So they're spanning all the way from the clavicle and over on this, really it's the scapula over here, and then the mandible, the manubrium. It's spanning all the way from that up to the hyoid. So it's the non-broken muscle, I guess you could say. So it's sterno, because it's from the manubrium, hyoid, sternohyoid. And this one, which is kind of going off to the side, that would be your omohyoid, right? So those are the 2 in the superficial layer of those infrahyoids. And I think this right here is probably sterno. This is probably both sternohyoid and omohyoid kind of being peeled off, so you can see the underlying 2 deep muscles. And this could be important, I don't know. But remember that on the thyroid cartilage, because that's roughly at this level, the thyroid cartilage, you have this line that goes diagonally. And so this right here would be that oblique line. And so here you have 2 muscles that are separated by that oblique line. So they don't make it all the way up between the sternum and the hyoid. So the one on bottom that goes from the sternum up to the thyroid cartilage, which is where the oblique line is, sternothyroid. And then the other muscle that takes it up the rest of the way is thyrohyoid. And so remember that you got to peel off those 2 muscles, especially the sternohyoid, kind of remove it and reflect it so that you can see those underlying 2 deep ones. But what I would do if I was on the test, I was thinking about which ones they are. I would look to see if I can see an oblique line. If you can see a pretty clear oblique line like you can here, move that out of the way a little bit, you can see that. That probably tells you that you're dealing with the 2 deeper muscles. And so then it just becomes, is it pointed to the one above or the one below? So, okay, so there you have sternothyroid. All right, next question. Identify number 6. It's like this one right here. I made a mistake on this one. Let's see. I had two of the same choices. Whoops. I did not mean to do that. That's my fault. That's what I get for making this so quickly. Anyway, well, let's go to this. So again, we got kind of the same stuff here. I think I actually meant to point to with number 5, I think, on this one. But in any case, it's the same kind of stuff. Here's the hyoid bone up here. And you can see this is the ear, so we have to be looking. Here's roughly where the chin is, right? So here's your hyoid. Always a really, really prominent white structure right there. And then here's your manubrium over here. So this muscle right here, this is probably sternothyroid. I think I did mean to point to number 5, but you can't really see the oblique line here, but this is looking like, to me, looking like we've got the deeper muscles underneath sternohyoid, and then here's omohyoid. Remember, omohyoid also has 2 bellies, except instead of being anterior and posterior like it is for digastric, here we've got superior and then inferior bellies of omohyoid. And then remember, it also has that tendinous intermediate part, which has a tendinous sling that comes from the clavicle, right? But anyways, here, the deeper muscle underneath sternohyoid and omohyoid, the top part, most likely it's going to be from the hyoid to the thyroid cartilage. So that would be thyrohyoid. And the bottom part's going to be sternothyroid, right? So hopefully that makes sense. And a few other things here that I thought were interesting. Again, here is the digastric, but this is a different belly of it. So this one right here is actually posterior belly of digastric. In this one, the anterior belly is not really visible. I don't know what happened to it, but this one actually, when I looked at the label, this one was actually supposed to be, for this picture, posterior belly of digastric. But remember, that one goes back, whereas the anterior one kind of comes up from the mandible, right? And then it has that tendinous sling that goes over the intermediate tendinous part. So here's posterior belly of digastric. The other thing also that we probably should remember is you've got vessels going up through here, right? So here, here's an artery, and then here's a vein. And remember that this one right here, the artery in this area is probably common carotid. And then right here, on the other side, would be the internal jugular vein. So this doesn't look like it's actually branched into the external or internal carotid arteries yet. But remember that while the carotid artery is going adjacent to the internal jugular vein, remember that you're going to have the vagus nerve that goes between them. So I think it was the last the last review session we had, I said that one of the things that would be good to remember is that when you have the carotid artery, up here it'd be external, but down here it's common. And then the internal jugular vein, you've got the vagus nerve that runs between them. So if there were like a little string between them, my guess that would be that's the vagus nerve. So hopefully that makes sense to everybody. And let's move on. Sorry, there was a mistake on that one. All right, number 7. This one. Yeah, and then just remember that anterior belly of digastric, that was cranial nerve 5, specifically the 3rd branch, mandibular branch B3. And then posterior belly, that was your facial nerve, cranial nerve number 7. All right, number 27, structure number 3. Let's see, this one right here. Yeah, he had a question on one of his tests. It was probably the test where we did this back in the very beginning of Anatomy 1, where it was all the, I think the answer actually was longissimus, if I remember, but he had all the 3 branches of the erector spinae, and then he had erector spinae as a choice. So remember when you're looking at these, and I asked about this in class today. I wasn't sure if it was exactly lumbar region, but really, I guess when you're differentiating these, I guess the thing I've noticed is that the most medial one is spinalis. It looks to be more muscular the highest up. I guess it's not like true, like, you know, cervical, thoracic, lumbar exactly, but the spinalis looks to be most muscular, most superiorly. Going in the middle, so lateral to that, this is longissimus, which is the middle one. And it's kind of muscular more in the middle. And then down here, this one would be iliocostalis. And this one's more muscular further down. So I guess when you're looking at them, assuming it's a good cadaver picture, it's a big if, right? But you can look at where it's muscular and kind of relative to the other 2. And I guess that can help actually differentiate those. Also remember, assuming they're more visible, remember iliocostalis, costal is rib. So remember that iliocostalis is inserting on the ribs, whereas these other 2 are not. And then spinalis is really right next to those spinous processes, so right on the vertebra. And again, just a thing to remember here. Remember, we've also got all of those these muscles in here, like rhomboid major, minor, levator scapulae, trapezius. Just remember that a lot of those, not trapezius, but like latissimus dorsi, remember that, you know, we know their nerves, their names. Like this was latissimus dorsi is thoracodorsal. These 3 up here, the rhomboids and levator scapulae, are dorsal scapular nerve. But remember, now we can add on to that, and he probably will, which cord of the brachial plexus, or at least which part of the brachial plexus it's coming off of. So make sure when you go back and look at those muscles in the innervation, make sure you also correlate it to the brachial plexus. That could be important too. Anyway, all right. Number 28, identify structure 8. Right here. Yes. So thoracolumbar fascia. So a few things about this. So I guess we're still in the same picture. So on the left side of this picture, so we can still see the lats there, latissimus dorsi. So we know that it hasn't really been dissected that much. So we're looking at the superficial layer here. Here we can see, well, here's serratus posterior inferior, but you can clearly see the erector spinae right here. So in this region down at the bottom, the thoracolumbar fascia has been removed. And what's exposed there on the right side would be the common either tendon or aponeurosis of the erector spinae on the right side. On the left side, this is still thoracolumbar fascia because we still have the latissimus dorsi here. And as long as that's there, this is still the thoracolumbar fascia. And so assuming that it hasn't been cut into really, when you're looking at the back side of this, the most superficial layer, that's the superficial layer of the thoracolumbar fascia. Also, it's the posterior layer because we're looking at the back side, so the superficial one is most posterior. So that's why this one was the answer. If we were looking at anterior layer or middle layer, depending on the way he words it, I think he said that he calls them the same thing, but that would actually be the deep layer because if you're looking from the back side to be anterior, has to be internal more, closer to the front side. So the anterior layer is actually deep. So again, make sure you look at the way that it's worded. And for this one, the deep layer, this was synonymous with anterior layer in terms of thoracolumbar fascia. And then remember that the common erector spinae aponeurosis, that is deep to the thoracolumbar fascia. And also another thing, I swear this was on the practical last time. There are actually 2 things I wanted to bring up based on this picture. One, I think he actually pinned the aponeurosis right here. He pinned it, and he said, what structure is deep to that? So remember the multifidus, so which is in the deep layer, the deepest layer. The multifidus is deep to the common erector spinae aponeurosis, which you see if you peel that over. The other thing to also remember, and I put this in here on purpose, with the trapezius, he asked about this on the written final, and I was going through it really fast and I missed it. Remember that the upper fibers, he could say for the trapezius, upper, middle, or lower, or he could say descending, horizontal, or ascending. Remember that for the upper fibers, I think the answer was probably upper fibers, but he put ascending, which I wasn't thinking, and I just put ascending, which was wrong. Remember that these upper fibers are descending because the way you talk about them is from the origin to the insertion. So the origin is on the spine. So on the external occipital protuberance, the nuchal ligament or ligamentum nuchae. So if you follow it from the origin down to the scapula, the upper fibers are descending. And then the lower fibers from the origin to the insertion are ascending. So make sure you think about it in terms of origin to insertion, or at least just memorize this, because that could very easily end up on there again. On the written final, or even the practical. He could pin a certain part of the trapezius, I suppose. But anyway, and then remember, trapezius is cranial nerve 11, so spinal accessory nerve. Okay. See if we can just finish these. Structure number 3. Back to the hands, by the way. Yes, so flexor pollicis brevis. So it looks like it was pretty split between these two. So on, let's see, where's the picture? Is it this one? Whoa. Okay, so here's our picture. That's about number 3, I think. So when we're looking at this, this is the pinky, so digiti minimi, over on this side. I think we would definitely be able to see the thumb. So the thumb is the pollex side. So that means over here we're looking at thenar muscles. The hypothenar muscles are over here on the pinky side, hypothenar. These are the thenar muscles. And really when you're looking at both of these, remember that the abductor, abductor, is always more external. So in this case on the digiti minimi side, number 2 would be the abductor because it's more out toward the edge. And same thing over here, number 4, this would be the abductor. So in this case, the thenar muscles, 4 would be abductor pollicis brevis. And then number 3 that would be flexor pollicis brevis. In both cases, the flexor is more internal into the hand and the abductor is more external, so to speak. So number 1, this would be that flexor digiti minimi brevis. And another thing, I don't know, he does things like this, so just be prepared. Remember that on this side, like number 2, for instance, this is abductor digiti minimi brevis. Remember that this one has 4 names. It's flexor digiti minimi brevis. And this one, excuse me, this number 2, I misspoke. This doesn't have a brevis after its name. This one is just, yeah, I think that's right, abductor digiti minimi. Because there is no abductor digiti minimi longus, so there doesn't need to be a brevis. This one is just abductor digiti minimi. This one has the brevis though, flexor digiti minimi brevis. And then over here on this side, 4 is abductor pollicis brevis. And then 3 is flexor pollicis brevis. So you've got abductors more external, flexors more internal. And then remember, both of them have an opponens. So if you remove these 2, you'd be able to see opponens pollicis. And then on this side, it'd be opponens digiti minimi. So hopefully that makes sense. And so these top 2, these would be the thenar muscles, and the bottom, those bottom 2 are going to be the hypothenar, which controlled the digiti minimi. All right, number 30. What nerve innervates structure 3? So same picture. So this is flexor digiti minimi. Excuse me, flexor pollicis brevis. Flexor pollicis brevis. Yeah. So when you're looking at, and I might have actually put something like this in the previous. If you go on Facebook, I think it's actually in the previous PowerPoint that I might have done over the last test review, or maybe it was 2 test reviews ago, I don't remember. But in any case, when you're looking at like the forearm, for instance, so remember you got 2 nerves, or there's 3, but there's, well, I don't want to say that. But remember that you've got the median nerve going down the forearm. The deep radial nerve becomes posterior interosseous, and so the other nerve that's going down, ulnar and median. So basically, I guess you could say the 2 nerves that are going down the forearm that make it in their entirety, so to speak, to the hand would be the median nerve and the ulnar nerve. And when they're going down the forearm, if you're just looking at your forearm, the way I remember it is, I always remember radial's lateral. Radial's, I don't know why I just remember that. Radius is the lateral bone, radial nerve, radial artery has to be on the lateral side, on the thumb side. So the opposite of the radius is the ulna. So the ulnar nerve has to be going along the ulnar side, or the medial side, or the pinky side. So the ulnar nerve is going along your, toward the pinky, so to speak. And then the median nerve's right in the middle. So, so median nerve's kind of going down the center part of the forearm. So when you get to the hand, if you take an imaginary line and kind of just take it down the middle of your second digit, really if it's on the thumb side of that, it's going to be some part of the median nerve. And then if it's on the other side of that, the rest of it is going to be ulnar. So there's only 4 structures in the hand, I believe, that are innervated by the median nerve. One of them is the first lumbrical, which is in this area right here, the first lumbrical. And then there's the thenar muscles, which is what number 3 was, one of the thenars. The only thing is, though, is that the thenar muscles, it's not, I guess, the median nerve proper. It's just a recurrent branch of the median nerve. So when the median nerve exits the carpal tunnel, that's another thing, remember the contents of that. When it exits the carpal tunnel, it continues a little bit, but it also gives off a branch called the recurrent branch of the median nerve. And that's what actually innervates the 3 thenar muscles. So make sure to remember that. And then also the radial nerve proper does not even make it past the forearm. It terminates like right here. So it doesn't make it very far. And the only part of the radial nerve that actually gets to the hand was that superficial branch, which is cutaneous sensory. The radial nerve does not innervate any muscles in the hand. And another thing is, remember he talked about this, there's extrinsic and intrinsic muscles. So intrinsic are the ones contained completely in the hand, like the muscular bellies are in the hand. So like on what we just did, the thenar muscles, you can see their muscular bellies are completely in the hand. So those are intrinsic muscles. Whereas something like flexor digitorum profundus, that has tendons that go into the hand, but the actual belly of flexor digitorum profundus is in the forearm. So that would be an extrinsic muscle. So make sure you remember those definitions. And then no dorsal muscles in the hand. They're all palmar. Okay, 4 more. Identify structure 4. That's this muscle right here. Yeah, so this picture was, again, this is straight out of his lecture today, I think. But anyways, we've got here, it's the anatomical snuff box. So if I remember right, yeah, this is definitely the snuff box, I think, right here. So we've got these 2 tendons right here. And then you've got the radial artery that travels in the snuff box. And again, we know it's the snuff box because this is the thumb side, so we can tell that in the picture. So radial nerve's coming through here. But remember, the radial nerve doesn't stay on the dorsum of the hand because the snuff box is more in the, I mean, it's on the side, but it's more or less on the dorsum of the hand. So the radial artery, which is on the thumb side, because everything radial is on the thumb side, it has to gain access to the palm. And so to do that, it's going to go through here and cross through the two heads of the first dorsal interosseous. So this is the dorsal interosseous muscle. And it's so close to the dorsum of the hand, it's in that web space between the first and second digit. It looks like it ought to be a dorsal muscle, but remember, if you're looking from the dorsal side, the most superficial muscle will be the dorsal interosseous muscle. And that can be a trick question when you're looking at this, because one of the choices was adductor pollicis. And adductor pollicis, that is the transverse head, is in this area. But remember the 4 layers of muscles. So adductor pollicis is in the 3rd layer. This is the deepest, the 4th layer. So actually, adductor pollicis would be on the other side of this. So if you removed this muscle, if you removed the dorsal interosseous, just took it off, peeled it off your screen, adductor pollicis would be on the other side of it. The other thing is, you can't see it in this picture, and I hope we have good resolution on the test, but the dorsal interosseous muscles, their fibers are not running horizontally. In other words, in the adductor pollicis, the fibers run from the thumb basically to the 2nd digit. They're running more horizontally. The dorsal interosseous don't run like that. They're more or less perpendicular to that, I think is what I saw. But if it was truly adductor pollicis, the fibers would be running from the thumb to the 2nd digit. They'd be running horizontally. So also remember that. But in order to see adductor pollicis, that is the transverse head, you'd have to peel off this muscle, and then you'd see it, because it's the 3rd layer. And so if you're looking from the palmar side, it would be superficial to the dorsal interosseous. But if you're looking from the dorsal side, it would be deep to dorsal interosseous. So hopefully that makes some sense. And then also, you can't see it here, but if there was asked anything about the oblique head of adductor pollicis, the oblique head is closer to the carpals, and it actually has an attachment on some of the carpal bones. So this one's not even near the carpals. If this was adductor pollicis, so adductor pollicis would be behind this. So this would have to be the transverse head, because it's not near the carpals. Anyway, that's enough on that. So I'm rambling a little bit. Okay, 3 more. Number 32. What nerve innervates structure number 4? Which is dorsal interosseous. Yes. Yeah. So yeah, when you're looking at the structures that are innervated by the median or recurrent branch of the median, there's only 4 muscles in the hand. You got the 3 thenar muscles, and then you have the first lumbrical. Everything else is by default ulnar. So that means lumbricals 2, 3, and 4, ulnar, and then everything else that's not thenar. So the hypothenar muscles, which control the digiti minimi, those are all ulnar. All the interossei muscles, so dorsal interosseous, palmar interosseous, those are all ulnar nerve. So if you just remember for the hand that there's just 4 structures, 3 thenar muscles, and the first lumbrical are the median nerve, with thenar being recurrent branch of it. Everything else then is ulnar nerve. And then again, there's no radial nerve innervation, that is motor innervation. Is it lumbricals 1 and 2? Is it lumbricals 1 and 2? Yeah, if it's lumbricals 1 and 2, okay, I apologize for that. I'll mention something whenever I post this. But yeah, if it's lumbricals 1 and 2, yeah, I'll make a note of that. So I apologize for that. Long week. So yeah, lumbricals 1 and 2, along with the thenar muscles. Those are going to be the median nerve, or its recurrent branch. Thanks, bud. And thanks, Rachel, also. Yeah. Ulnar nerve is everything else. So couple more. Number 33, identify the structure number 4 on the anterior antebrachium. So here's number 4. There we go. Yeah. So on this one, one thing I kind of found also, and let me see if I can find it. Good picture of this. This will work. So here we're on this is the anterior forearm, right? The first muscle I like, if I know it's the anterior forearm, and also something that can help you determine, is that it is the anterior forearm, is the pronator teres, because it doesn't go anywhere near the wrist. It still originates here on the medial epicondyle, the common flexor origin, but it doesn't go anywhere near the wrist, so it runs really diagonally. It kind of sticks out like a sore thumb to me. So that helps me know it's the anterior forearm. The other thing about this that can help is that the pronator teres, if you notice which direction it's running as it goes down the forearm, it's running toward the thumb side. Because over here is brachioradialis, so that has to be the thumb side. So pronator teres runs toward the thumb. So if you follow kind of where it's going, and let me copy and paste this somewhere, back up here, wherever we were. Must be this one. Okay. So number one over here, this is pronator teres. So it looks like it's running in this direction. So over here must be the medial epicondyle over here. That's the common flexor origin. And then it's running over here. So it's running laterally as it goes down the forearm. So this side must be the thumb side over here. So over here must be more ulnar. Over here must be more radial. So you can identify a few things. You can cross pronator teres off the list. Brachioradialis doesn't go down. It goes down pretty far, but I don't know that it's not muscular down at this point, because here's the wrist right here. So I don't know that brachioradialis goes down that far muscularly, and this looks to be muscular. So it's not brachioradialis. And this over here, the one with the really long tendon, he made a point of saying this. This one was palmaris longus. I just remember palmaris longus, it has a really long tendon. That's going all the way down to the wrist. And so this we said was the more radial side, because pronator teres is going toward the radial aspect, the thumb side. So this one would be the flexor carpi radialis. And it was a little bit, it might have been a little bit higher resolution before, but over here you can see the flexor retinaculum kind of over here, and this is where the carpal tunnel is. And also it looks like flexor carpi radialis is getting ready to go into that carpal tunnel. But remember that flexor carpi radialis has its own special, the presidential tunnel, right? There's 10 structures in the carpal tunnel proper, but then flexor carpi radialis gets its own tunnel on the lateral side of the carpal tunnel. And I could see him asking about the structures that are in there. Remember, you've got, let's see, was it, yeah, flexor digitorum profundus, that's 4, because there's 4 tendons. 4 more for flexor digitorum superficialis, and you've got the median nerve, and then, yeah, flexor pollicis longus. Rachel said that. Yeah, thanks for helping out on that. So 10 structures in there, and then you've got flexor carpi radialis, which sits on the lateral side in its own little tunnel, right? Okay. Last question, number 34. All right, what nerve innervates structure number 4? So that is still flexor carpi radialis. Yeah, so this one's median nerve. So let's see. So here you've got all these flexor muscles, right, up here, that are all originating from that medial epicondyle. So that's your common flexor origin. There's really only kind of one really two exceptions here with the innervation. And you kind of think about it of the external muscles. So kind of, you've got these three in the middle. So you've got pronator teres, flexor carpi radialis, and palmaris longus. They're kind of in the middle because they're flanked on the lateral side by brachioradialis, and then on the medial side by flexor carpi ulnaris. So when you're looking at those anterior muscles, on the lateral side, which is the radial side, brachioradialis does get the radial nerve. So it gets the radial nerve. And there's only a few other muscles that got that or a branch of it. Because remember, supinator got that. Supinator has a branch of the radial nerve. And I believe it's actually the deep branch. And then there's, remember, extensor carpi radialis longus is radial nerve. And then there's extensor carpi radialis brevis, which is the deep branch of the radial nerve. So there's really four muscles there that the radial nerve deals with. But if you look actually at flexor carpi radialis, even though it's named radialis, notice that they're really all four of these muscles, the bellies of them, the muscular part is on the medial side. The reason it's named flexor carpi radialis is because the tendon goes toward the radial side. But nerves don't innervate tendons. They only innervate the muscular part. So the muscular part of flexor carpi radialis is more medially placed. It's on the, more or less on the pinky side or ulnar side. So it doesn't get the radial nerve. The three muscles in the middle here, they get the median nerve because they're in the middle. And then brachioradialis gets the radial nerve, and flexor carpi ulnaris gets the ulnar nerve. So you've got ulnar nerve on the ulnar side, radial nerve on the radial side, and then median nerve hits the three in the middle. And then I'll just mention this real quick since we're practically done here. Let me actually see if I can put it in here. Yeah, so there's a few other muscles here that if you look at these two, which are all probably also important, flexor digitorum profundus, flexor digitorum superficialis, they get the median nerve because they're in the middle. This one, most of it's median nerve. So if you look at flexor digitorum profundus, which is the blue one, the side that's closer to the side that's closer to the ulnar aspect, which is the pinky side, it gets the ulnar nerve, right? Because it's closer to the ulnar side. But the part that's closer to the, basically the thumb side, which is the more median nerve part, this gets the median nerve. So flexor digitorum profundus is split in half. And when you think about this muscle, if it were to come up, just remember to divide the muscle in half. The part that's closer to the ulna gets the ulnar nerve. The half that's further from the ulna doesn't get the ulnar nerve and therefore gets the median nerve, just like flexor digitorum superficialis, which isn't shown here. So hopefully that makes sense. And then when you get to the really deep structures, where am I? Really deep structures, like these ones. Flexor pollicis longus is deeper. Pronator quadratus is deeper. You get anterior interosseous nerve. And just remember that anterior interosseous nerve is one of the branches of the median nerve. So when the median nerve is in the anterior forearm, it gives off the anterior interosseous nerve. But remember, the median nerve still goes down to the hand. It doesn't terminate as the anterior interosseous, like the deep radial one does for the posterior interosseous nerve. This one gives off the anterior interosseous, but then the median nerve still continues down to the hand because clearly it has to be able to innervate the first and second lumbricals, right? And then the thenar muscles. So, okay. Let's see. So Evie says, if anyone has Newman book, pages 305 to 308 has illustrations of the brachial cords and the muscles. Each follows distally to the hand and the sensory portions as well. Yeah, so definitely if you're going to study, go ahead and check that out. All right, so that was probably, I think, the first time we actually got through every single one of the questions. Normally we miss a couple of them. So, so that's all we've got for today. It's been a very, very long week, very long semester, I would say. But thank you guys for coming on out to this. I enjoyed a lot. I will post. Let's see. I know I recorded this, so I will, as soon as we get off here, it'll start to upload. I'll put it on YouTube and then Facebook, and then has a lot of extra stuff in here, but at least it has all the stuff that we did. So I'll post that on Facebook also. And So wish you guys the best. Thank you all. Good luck tomorrow, everyone. Remember that unless you have some other excuse for anything, remember he wants us to take the lab one, I think at 8. Just like I think we actually switched in immersion, but I think it's 8 for the lab one. And then I don't know when does anyone know when he wants us to take the lecture one or the written one? Or is it just kind of whenever for that one?
In his thing, Kevin, he just sent out, he said we could just take any whenever we want.
Oh, we can just take them whenever.
Yeah, he said we don't have to notify them or anything. Just take it when it's most convenient to us. Is in that message he sent out.
So you said we do not have to notify him?
No.
As long as it's just done by the end of the day. Okay.
Basically, yeah. Yeah.
Okay.
And hey, real quick, can you, by any chance, can you post the links to those old Kahoots? Because I was trying to find them to retake them, and I couldn't find them.
Yeah, I will. Yeah, let me do that. I will get on that as soon as we get off here. Yeah, I saw your
Hey,
comment.
no rush. Thank you.
Yeah, no problem. No problem. So yeah, thanks guys, and you guys definitely helped out a lot with this because it's obviously a lot of material and hard to remember every single thing. So thank you guys. Good luck to you all. We get a week break, so that's always good. And I will see you guys next semester in semester 2. So thanks guys for coming out. Good luck to you all too.